Hi, good evening, everyone. And it's my pleasure and honor to have been associated with the new season of Case Files. And Dr. Amit Gupta has tremendously and successfully started this program, and it has actually gained a lot of uh, 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 what to say, a lot of attention in actually in the field of medicine. So today we are starting afresh, and we have with us Dr. Jyoti Bajpayee from Lucknow. And hello, Dr. Jyoti. And she'll be coordinating with me with throughout the season of these case files, and we'll be like uh, we'll be connecting the doctors throughout the pan India, where we would actually try to explore the various medicine fields and the so basically I think we should actually quickly start the program because we are getting late. So we have Dr. Anumiti Jain from Jabalpur, Dr. Meenal. Hi, ma'am. And so we'll start it, right? Dr. Jyoti, could you please
Yeah,
start the yeah.
So, thank you, Dr. Abhishek. And I would like, this is my proud privilege to, I am conducting this case file first time. And I am very thankful to Dr. Anuj Maheshwari, sir, and Dr. Amit Gupta, sir, for giving this opportunity and this responsibility to both of us. So, I would like, we will do some justice on this. And today's topic is very interesting because of CNS tuberculosis and hypercalcemia. These two topics are very important, and we are so blessed. We have a very good and beautiful lady with us, Dr. Preeti Singh, who will moderate this session. And she is MBBS, MD in General Medicine, Diploma in Non-Invasive Cardiology. She is head of Department of General Medicine, AIMS Bhatinda. So I welcome Dr. Preeti from the whole team of ACP India, and she is also member of ECP Council. She has written many book chapters. She is a fellow of various societies, and she has write up some of good publications too. So this is my privilege, and I am honored to invite Dr. Preeti to moderate this session. And I am especially very thankful to you. And now, without delaying too much, I request Dr. Preeti, dais is yours.
Thank you, Dr. Jyoti. Thank you for your very kind words. Good evening, everyone. Thank you, respected Dr. Anuj Maheshwari, sir, Dr. Amit Gupta, sir, for giving me an opportunity to be on this esteemed platform. So not to delay the session, our first speaker for today's session is Dr. Anumiti Jain. She is Associate Professor Neurology, NSCB Medical College, Jabalpur. Ma'am has more than 9 years of work experience, and she has many publications to her credit. She is a well-known speaker at regional, national, and zonal conferences. So today she'll be talking about CNS tuberculosis and its unusual presentation.
No, Dr. Preeti, just because I think Dr. Anumati has told that her laptop has been crashed because
Okay,
of some unusual. So she'll be presenting the pearls of neurology. I'm really
okay,
sorry.
okay.
Uh,
So
so
let's start the session for Pearls on Neurology.
Yes.
Over to Dr. Anumati Jain.
Good evening, everyone. Thank you so much for inviting here. And I would, without wasting time, I would like to start with the session. And are my slides audible?
yeah,
Yes.
definitely, yeah.
Just a minute, some issue.
You put it in the slideshow mode, no, Anumati.
Yeah, I'm just doing it. Yeah. So I wanted to actually share some unusual pulse of neurology. And so we will start with case 1. So this patient came to us, a 56-year-old male, is a businessman and politician. So you can understand the level of activity of brain of this person. So the attenders came to us with the complaints of behavioral changes and some memory disturbances from 6 months. So it was a very less period of presentation. And the attenders complained that the patient is now more of withdrawn. He is now withdrawn from the surroundings. He remains aloof from the family and is not indulging in prayers and watching TV as he used to do before. And he enjoyed that. And he prefers to stay at home, not going for any parties or for social activities. So this was the behavioral change. They also observed that there was slowness in the activities of daily living of this person. That they said that while putting clothes or eating or replying to some queries, talking, this patient was slow. So this was the other thing which they observed. The third thing which they observed, which was very important, was forgetfulness. Forgetfulness was in the form of misplacing articles of common use, like recent memory impairment. Just now he's kept something and he's forgetting that. Also, there was difficulty in doing some complex tasks, like frequent accidents used to happen while he was driving. And occasionally, he used to drop things from the hand. Past history, the patient had a history of coronary artery disease. Post PCI, he was in 2009. And also from elsewhere, he was diagnosed as a case of depressive disorder and was on clonazepam. No renal or hepatic or any other systemic disease history as of now was available to us. And as per the attendants, and the patient was vegetarian with no addictions, with no history of multiple unprotected sexual intercourse. So this was the history, and we came to general examination after history, which was normal. General physical examination was normal. MMSE, when we did, the MMSE score was 17 out of 30, and majorly the attention was impaired. And he lost points in orientation, serial 7-digit subtraction, recall, and construction. And overall, if we say lobar examination, the frontal lobe was impaired grossly. Temporal, only the recent memory was impaired. Remote memory was intact. Parietal was grossly impaired and occipital was impaired. On motor examination, there was generalized hyperreflexia with release reflexes present, and extrapyramidal involvement was there in form of generalized rigidity and bradykinesia. So we may move forward with this examination. Now, what is the diagnosis on the basis of history, examination? Any other thing which the audience want now? I think the blood investigations. The next thing. So we went for the investigations, where the main thing which I would like to highlight was creatinine was 1.49, borderline elevated, and bilirubin was 1.6, and AST/ALT was elevated. CSF examination was normal. Thyroid profile, HbA1c, and triple markers were negative. So we proceeded further. No clue. EEG was done, which was suggestive of no epileptiform discharges, and there was mild diffuse encephalopathy. So now we went for the MRI. MRI image, you can see on your right side is a T2 image, and the left side is a FLAIR image, where I would show my pointer. These are the basal ganglia. These are the basal ganglia, substantia nigra hyperintensities in the T2 image. Now, also this area is well hyperintense in the diffusion images. If you can see my marker, they are hyperintense and they are hypo in the corresponding ADC images. So substantia nigra hyperintensity was present. What is the diagnosis? Any other information needed? So as a part of workup for the rapidly progressive dementia, we did serum ammonia. So it came out to be high, 186. So when we went for the USG ultrasonography, and the spleen had normal ecotexture, liver showed mild coarse liver ecotexture was there. So we went for a fibroscan. Fibroscan showed liver, the thickness of LSM was 54.2. So this was very high, suggestive of cirrhosis with portosystemic encephalopathy. So this was a case of cirrhosis with portosystemic encephalopathy as a cause of rapidly progressive cognitive decline. So this was a management we gave, as he was a case of CAD post PCI. So we gave ecosprin, lacilactone, and carvedilol for cardiac purposes, and we started lactulose and rifagat. And after 2 weeks, the MMSE came up to be 30/30, which was 17 out of 30. And the lobar functions, which were grossly impaired, they came up to be normal. And there was a marked full improvement in the patient's mood and affect. So if we go back, the MRI showed the hyperintensities in the globus pallidus. So this is the sequence in cases of photosystemic anastomosis. Here we get symmetric high signal intensities in the globus pallidus and substantia nigra. And so this was what we got in the MRI. And so the learning point from this case was that general physical examination provides the clue, and keep treatable causes in the list of rapidly progressive cognitive decline. It is treatable in some cases. So this was one case. The other case is again, I want that slide screen.
Is there any problem, Dr. Anubhuti?
I wanted that actually. Just a minute, I'll do that.
Right, take your time.
Yeah. So the second case is 54-year-old gentleman, known case of diabetes with hypertension. And he presented in a very unusual symptoms of brief episodes of unresponsiveness, and which were lasting for 10 to 12 seconds. And this was at that time.
Excuse me, ma'am, your slides are not moving.
Slides are not moving.
Yes.
Anubhuti, just put it on the slide mode, no slideshow.
But
It's
I guess
down.
it is showing the last slides. It is showing slide 17 of 17.
Now.
No, you just go to the extreme right downside, no downside, bottom right, where you can see the slide, no, the slideshow logo or icon. You can see it, no?
Yes, now the slides are there.
Now the slides are there.
Okay. So this 54-year-old gentleman was a known case of diabetes with hypertension, and he presented with some unusual episodes of brief episodes of unresponsiveness for near about 10 seconds. And this was in October 2018. He presented to us, and the symptoms were very unusual. He used to see some episodes of a TV serial, and at that time he was seeing that serial, that episode, but at that time he was unresponsive. So he used to tell us that I am seeing some episodes of a TV serial for some time, for some seconds. And at that time, the attenders say in the family that I'm not responsive. At that time, he has so this was visual hallucination and with behavioral arrest and speech arrest. And he also had a post-ictal confusional state of 30 seconds. So he had this frequency of 5 to 6 episodes of these manner per day. So he presented to us in neurology services of PGIMER Chandigarh, and on examination, CNS examination was normal, general physical was normal, CSF was normal, but yes, EEG was showing localization related epilepsy. So focal epilepsy evidence was there. So clinical and EEG correlation was there. So we started anti-epileptics for this patient, and we planned imaging for this patient. So we did the MRI brain of this patient, and these are the flare images. Here, if you can see my cursor, this is a flare hyperintensity on the left side of the parietal area of this patient, and corresponding contrast images showing enhancement in this area. Also, the flare showed anterior temporal and mesial temporal hyperintensity. Let us see the contrast. Again, it showed a ring enhancing, multiple ring enhancing lesions in the anterior temporal lobe, here and here. So imaging was suggestive of conglomerate tuberculomas in the temporal lobe and the periventricular area on the left side. So we started anti-tubercular drugs for this patient. And but then on follow-up, this was in October, he came, within 20 days he presented. So after 3 months of the follow-up, the seizure frequency remained the same. He had 2 to 3 episodes, sometimes 5 to 6 episodes per day. And since December, again, the seizure frequency increased to 10 to 15 episodes per day. But that means he was not responding to the treatment. And so we again planned imaging in this case in view of no improvement. And so we repeated the MRI. So these are again flare axial images of the brain. And if you can recall that periventricular area here, this periventricular area is hyperintense. The area is larger now. And this is the contrast enhancement. This area is again larger, contrast enhancement area. And now let's see the temporal lobe. The whole of temporal lobe is hyperintense. And this is the contrast enhancement, which is seen in the anterior temporal lobe, now involving the medial side, and the almost the edema is extending to the whole of temporal lobe. So we decided now this is not tuberculosis, and CSF was also not suggestive. It was just this thing, correlation we did, but we repeated the CSF. CSF again came normal. We did FDG PET whole body, and it showed FDG avid areas in the similar areas where there were hyperintensities in the brain. So this you can see that left periventricular area and the temporal area. Whole body PET was normal. Now what is the diagnosis? So we were left with the biopsy of that patient. So we asked the neurosurgery people to do the biopsy of the area from the anterior temporal lobe. And the biopsy showed high-grade glioma. So learning point in this case was, excuse me, strict follow-up of the patient is important. We might get a clue if the patient is not improving. Think beyond and think wide, and keep maximum differential diagnosis on the basis of patient's profile, symptoms, and signs, and work vigorously on all significant lines. Thank you.
Thank you, Dr. Anumati, for very interesting and very informative case presentations. And I am sure they will add to our knowledge and help us all in our clinical practice to broaden our differential diagnosis. So we should keep these things in mind. Thank you, ma'am.
Thank you so much. I would like to thank Dr. Amit Gupta sir, Dr. Abhishek Srivastava sir, and the whole ACP team. Thank you.
Thank you, ma'am.
We can
Very
take
interesting.
we can take some questions also if there are some questions.
Yeah. Yes.
So, Dr. Anumiti, first of all, many thanks to you for accepting the invitation and presenting two very interesting cases in neurology. We know that neurology has always been a tough thing for the residents, and I am sure they must have found it very useful. So, Dr. Preeti, you can initiate the discussion, and we can have discussion for another 5 to 10 minutes. If there are any questions, yes.
I can't see any questions here. So there's no question.
Dr. Anumiti, if we go to your case, then is the patient still under follow-up, and how the patient is doing, and what is the current treatment plan for your patient?
Sir, that hepatic portosystemic anastomosis, that patient, the case 1 is perfectly fine now. And actually, unfortunately, we got all the viral panel did for this thing. Cirrhosis were negative. So probably some autoimmune cause must be there, but the patient is still in follow-up and is fine. The glioma patient, I don't know, sir, because I left PGI 2019, so I don't know much about that patient.
Actually, we have seen a very large number of these cases because in Punjab area, there's a lot of this alcohol abuses there. So we frequently see cirrhosis with portosystemic and encephalopathy and with all the portal hypertension, all the complications. And we in fact, sometimes we get EEG also done in these patients. So we have I think every day, I think we must be having 10 to 12 patients in a ward with this problem. So it's in this region, it is a very large number of prevalence is present in this Punjab region.
Yes, but after repeated history, he was not giving any history of alcohol. We were after is this thing, but no history of alcohol we got. But yes, you are right. This is very much prevalent in that area.
Yes, ma'am.
प्रीति मैडम पंजाबियों को बदनाम कर रहे हो आप.
Actually, one
was saying कि alcohol is very much synonymous with Punjab, is it? ऐसा मत करो यार.
Ma'am, out of two wards, one of the ward is with the cirrhosis and its complications.
You can have a bias towards admission with CLDs, but don't say that Punjab and Punjabis are only with alcohol.
Sir, Meenal ma'am, we caste also are very known for na.
Yeah, please enlighten Preeti, yaar. We are very good people. Punjabis are good people.
Punjab is very close to my heart because I have spent all 3 precious golden years in Chandigarh. So I am actually, I want to be with you.
I think it is.
Join us.
Yes, alcohol is a problem all across the world, and in almost in every.
Amit is not a problem. The problem is human behavior.
So yes, so alcohol abuse is
moderation. Anything in limit is acceptable. So alcohol per se is not a problem, but we should know how to make the best use of whatever we have in life.
I think this program is live and this is the discussion. We cannot give a official statement.
Official statements are not there.
Yes. So if there is any other question, then I can see Dr. Anubha Srivastava there and Dr. Mukhya Prabhu also. He is from Manipal. Dr. Anubha is from Allahabad Medical College. So if there are any other questions regarding the neurology, so we have Dr. Anumiti, we can ask her. Dr. Jyoti, you have raised and you would like to say something. Yes, please.
So Dr. Anumiti is a very nice presentation. First of all, I would like to congratulate you. And one question from the second case of mine for my residents also. So in this case, you have suggested that initially you told that it is a case of tuberculoma and later it came out glioma by the biopsy. So it's a very difficult to do biopsy in the brain lesions. As a center, we are a tertiary care center, but a lot of time we are struggling with TB malignancy, and this is a scenario. So how can you any other markers or any other different methods to diagnose on the basis of radiology? You can suggest some points to our residents. How can you define as a early, this is a case of malignancy or tuberculoma? How will you differentiate it? This is my question to you.
Yes. See, one is clinical history. So clinical history is always and always important in medicine. So history of low-grade fever of at least a fever of 2 weeks, near about 10 to 14 days history is always there. This patient had no history like that. So 2 weeks history of fever, yes, weight loss, appetite loss can be there in malignancy also. But history of fever, 1. I had done a study in PGI where I studied 100 cases of CNS tuberculosis, out of which I got 97 cases who were positive for extracranial sites involvement in cases of CNS tuberculosis. Apart from brain, some or the other part in the body was positive in the PET scan in cases of CNS tuberculosis. So I am of the thought that you will get some or the other evidence in cases of CNS tuberculosis, either if you do a chest X-ray or a USG abdomen showing a mesenteric lymphadenopathy or history of some genital tuberculosis. Also, I got some adnexal FDG avid areas in the PET scan. So there is some or the other extracranial involvement in cases of CNS tuberculosis, because 97% is a very big number or percentage which I got. So something is there. So either a chest X-ray will rule out, or a USG abdomen, or a CT abdomen, or a CT chest. That would be helpful with history and CSF examination. CSF here was normal. So CSF, if you get cells around 150 to 200 and with predominant lymphocytic polymorph, I'm not sure, I got both the varieties, and ADA is also not that specific. But if you get a CBNAT positive or gene expert positive, TVPCR positive, then it is a short case of tuberculosis. Here we did not had a clinical history of fever. CSF was also normal. So these points are against. And also, if you would recall that the FDG PET whole body was negative apart from brain. So that means there was no extracranial involvement of any site. So that was also against tuberculosis. You will get involvement extracranial in usually all cases of tuberculosis, some or the other.
Okay, thank you.
Thank you, ma'am. Thank you, Dr. Anumati, for this wonderful presentation.
Thank you.
So our next speaker is Dr. Meenal Mohit. She is consultant endocrinologist at Manipal Hospital, Jaipur. Dr. Meenal Mohit has a lot of achievements to her name. She is mentor Team India Von Osler Cup ACP 2021, pioneer of Cloud Clinic venture during COVID-19, editor MediBeats, reviewer of many prestigious journals. She's the founder secretary of Metabolic Club Jaipur and governing council member RSSDI Rajasthan chapter. And she has numerous publications, posters, and chapters in book to her credit. Welcome, Dr. Meenal Mohit.
Thank you, Dr. Preeti. So at the outset, my sincere regards to the governor of ACP, Dr. Anuj Maheshwari, the council of ACP, and my very close friend Amit, who has invited me for this evening, the case-based scenarios that we are discussing here. Anuba is here. Anuba, thank you so much for considering me for this event. So thank you, my chairpersons, or my moderators, Preeti, my co-speaker, Anumati, Abhishek, Jyoti, thank you so much. So we will be taking a very interesting case, a very common one, not a very rare case, of course. So if you allow me, I'll just share my screen. Okay. So can you see my screen?
Yes, ma'am, it's visible.
Fine. So we will begin with a case of hypercalcemia, which is a very simple case. We all come across calcium, raised calcium every other day. So how it began, actually, this is a 24-year-old boy, actually. He was a very thin, lean, thin 24-year-old boy. His actual real name is Ravi. So he came to me and he was just found to have no history, but incidentally at his residential place, somebody found that he had a very high serum calcium. Now, with this high serum calcium, he was referred, And what are the differential diagnoses that come to our mind when we talk of high serum calcium, raised serum calcium? Obviously, we think either it is PTH mediated, that is, either it is a case of primary hyperparathyroidism. When we talk of primary hyperparathyroidism, incidentally, we have few syndromes like MEN1 and MEN2A. We also consider even familial hypocalciuric hypercalcemia. And very rarely, if it is an old CKD, we do consider tertiary hyperpara. But at the same time, we also have, because we are a poor country and a malnourished people and strata are there, so we also consider even the secondary hyperpara or maybe a malabsorption induced hypercalcemia. So it can be a PTH independent hypercalcemia. So it can be because of malignancy, it can be because of vitamin D toxicity, it can be because of malabsorption, malnutrition, or it can be a chronic granulomatous disease. So these are all the differentials that come to our mind when we talk of hypercalcemia. Now, in this case, of course, what we did, we had sent, obviously, as a second step, you will always send a PTH. So what are the most common presentations of primary hyperpara? In 80% of the cases, a primary hyperpara remains asymptomatic, and raised calcium is the most incidental finding that they come to surface. Then there can be increased, prolonged incidences of hypercalcemia and hyperpara will lead to increased bone turnovers. There can be osteoporotic bones and there can be frequent fractures. But before that, of course, you will find that the typical book picture of bone stones, abdominal moans, and the psychogroans. So this is a typical picture of primary hyperpara, or very rarely it can be presented with osteitis fibrosa cystica that we really read in our books, and very rarely it can also present with nephrolithiasis. If you go the reverse way, most of the cases of nephrolithiasis, only 5% come out to be primary hyperpara. So typically you will find in hyperpara, there is these bone tumors, the cystic bone tumors are there, or there is subperiosteal resorption, or you will find the typical salt and pepper skull. But in this child, in this boy rather, not a child, 24 years, nothing of the clinical picture of radiology was actually evident. Now, nephrolithiasis, as I told you, if you go the reverse way, only 5% of the patients with kidney stones actually have hyperpara. So mostly the presentation or the clinical features remain because of hypercalcemia. And the typical picture of hypercalcemia, like kidney involvement, it will come up with polyuria, polydipsia, nephrolithiasis, nephrocalcinosis. GI manifestations like anorexia, nausea, vomiting, there can be constipation, muscle weakness, bone pain, osteoporosis, confusion, depression, fatigue, and cardiovascular symptoms like QT interval shortening and bradycardia are the known causes, known symptoms of hypercalcemia. Now, how do we diagnose this? Of course, we send a PTH. Normal values of PTH are around 10 to 60 picograms per ml. And if you find a frankly elevated PTH, then of course, we are dealing with primary hyperpara. So coming back to our case, this patient had high calcium and high PTH. So this is a case of primary hyperpara. Now, primary hyperparathyroidism is likely to be either because of some parathyroid adenoma, or is it syndromic, or is it is a familial hypocalciuric hypercalcemia, right? So what do we do? To differentiate the primary hyperparathyroidism from FHH, which is another common entity, we need a 24-hour urinary calcium. If the urinary calcium is more than 400, definitely it is not hypocalciuria. So it is in favor of primary hyperpara. But if the urinary calcium is less than 100, then it is in favor of hypocalciuria. So we can screen the other family members for the entity familial hypocalciuric hypercalcemia. This did not turn out to be the case in our patient. This is a standard algorithm that you measure the calcium, which is raised incidentally. And second step is measure PTH. If the PTH is elevated, we consider either FHH or primary hyperpara. You measure 24-hour urinary calcium, and you reach a diagnosis that this patient of ours was a case of primary hyperpara. Now, in case of primary hyperpara, of course, you always send a urinary excretion of calcium, you send a serum phosphate, magnesium, and vitamin D also. The routine workup. And of course, you do a BMD because you know that these are primary hyperpara patients will have a cortical bone loss, which will be coming up as osteoporotic bone either at the radius or the LS spine or the neck femur. So now this patient, we have hyperpara and we have hypercalcemia. So do we need something more? Do we need a screening, some scan, some parathyroid scan to make a diagnosis? Definitely no. The diagnosis is clear that the boy has primary hyperpara along with hypercalcemia. But we do need a scan to localize the source of this hyperpara. So for localization, the investigation of choice is a system-AB scan. 99M technetium system-AB scan is conducted, and in 80 to 85% of the cases, the most likely cause is a benign solitary adenoma, that is a parathyroid adenoma. It can also be multiple adenomas, it can be parathyroid hyperplasias, and very rarely it can be carcinomas. So 99 technetium scan is done. There are advantages that it is easy to localize, but disadvantages that along with underlying thyroid disease, there can be some confusion. And even at times, this system-AB scan can miss a small adenoma. In such cases, we do a SPECT, that is photon emission computed tomography. So photon emission CT is done along with system-AB, and the coupled images can give us a more likely diagnosis of a parathyroid adenoma. So this was done, and we could pick up a parathyroid adenoma. At times, you might even miss on SPECT, and in that case, you need a dual isotope scintigraphy where we use a thallium along with system-AB. Some sonography, sometimes we do pick up on sonography, but sonography has its advantages that it is available and easy and inexpensive, but the disadvantage is it is not very dependable, and it is very much dependent on the radiologist. We can also go for MRI scanning to localize the mass. You can also even go for invasive localizations because you might doubt whether it's a functional mass or it is a non-functional mass. So coming back to our patient, the patient underwent system-AB scanning and found to have a right parathyroid adenoma. So what do you think? A hyperpara, simple case, hypercalcemia, hyperpara, you can just send the patient for a surgery and ask the patient to undergo a surgery. And the case is over. We have a primary hyperpara, parathyroid adenoma. So what do you consider before sending your patient? What are the inclusion criteria? Whenever the serum calcium concentration is above 1 milligram per DL, above the normal level, okay, creatinine clearance is decreasing. So it is affecting the kidneys, that is less than 60 ml per minute, okay. BMD, yes, you do a BMD and you find osteoporosis when the T-score is less than -2.5 and age is less than 50. So do you think our patient is actually fitting here? The calcium level is raised, yes. Kidney was normal, BMD was normal, age, he's 24, so definitely less than 50. So this is our patient. So there was a catch. He is 24, his BMD is still normal, calcium is raised, and he has one adenoma. So this is the catch. Now we go for some detailed workup and we just get to know the family history. And the mother comes and says that, yes, she has already had an operative history and she has been resected for a pheochromocytoma. Father has no significant medical history. The brother, who's almost of the same age, 2 years elder rather, but he refused any medical workup. He refused for any checkups. And he says he is absolutely fine. But now there was a catch, a mother with a history of pheochromocytoma and a son with a history of parathyroid adenoma. So a family workup was done. Mother found to have raised calcitonin levels as well. Though she was euthyroid, but she had a raised calcitonin. She was normotensive post her surgery, normocalcemic now, but her RET oncogene came positive. And as we know, it's an autosomal dominant condition. Father was also worked up, RET oncogene came negative, brother denied any workup. Now our case, he was still normotensive, his calcitonin levels were normal, he was euthyroid, but his RET oncogene came positive and his MIBG scan gave us one adrenal mass. Now because it was mother coming from the mother, father was negative. Because it's an autosomal dominant condition and it's coming from mother, we also asked for a workup of the maternal grandparents. But maternal grandparents were alive at 65 and no medical history. So we don't know from where did the mother, like how did the gene mutation came here, but there were some genetic mutations, of course, which began from this index case became the mother. And our patient, he has now a hypercalcemia, hyperparathyroidism, a solitary parathyroid adenoma in the right parathyroid gland, along with a RET oncogene positive. So we have a case of MEN2A. Now, MEN2A was diagnosed on the basis of adrenal mass. The workup of adrenal mass gave us raised urinary catecholamines, though he was not normotensive with no episodes of no episodic hypertensions, no paroxysmal episodes of hypertension. Calcitonin was normal, but in spite of all that, the first surgery to be taken up after the diagnosis was not parathyroid, but was FAO resection. Though there was no documented FAO, we had a MIBG scanning, which gave us adrenal mass, which was having increased urinary excretion of 24-hour urinary sample, gave us a positive urinary catecholamines levels. So he also had to undergo a FAO resection or the adrenal mass resection, which was followed by a complete neck resection of thyroid as well as the parathyroids. After some time, the patient was discharged from the hospital on calcium supplementation, on thyroid supplementation, and with strict instructions of a regular annual follow-up. In spite of that, the patient was readmitted to the hospital in less than 1 month, and this time the presentation was with tetany. So he was having symptomatic hypocalcemia. Serum calcium was found to be some 4 to 6 milligrams per dl. So the child, the family took the replacement of calcium as one of the doctor's fancy drug, that they don't need calcium and multivitamin supplements. They continued with the thyroid supplements, of course. So the boy was euthyroid, normotensive again, no rise in blood pressure, but he became tetany. He developed tetany. The Shostak's was positive because of the low calcium. And this time he was replaced on vitamin D calcitriol, along with very clear instructions of following calcium for 6 hourly. So the common complications of the parathyroid surgeries or the thyroid surgeries, of course, the routine surgical complications stand, that is hematoma. But more importantly, we deal with post-operative hypocalcemia. We also deal with permanent hypoparathyroidism, permanent hypothyroidism. And there can be other surgical complications like wound infections or the recurrent laryngeal nerve injury. At times, there can be hyperthyroidism if you're dealing only with the parathyroid surgeries, but because this case had a complete thyroid resection as well, because most of these patients do land up with MTC, that is the medullary thyroid carcinomas. So this patient underwent all the 3 surgeries. And to add to it, though it is not related to our case, the mother was readmitted, and even we did a thyroid resection for the mother. So this is about the MEN2A syndrome, which is not a very uncommon diagnosis if you keep your eyes open. Just to add to that, for example, today itself we had one MEN1 rather, where we had a pituitary mass with pancreatic neuroendocrine tumors, and we also had the thyroid involvement. So it was a PEN-para case, the parathyroids, thyroids, parathyroids, and the pancreas and pituitary involvement. So maybe we'll take up MEN1 sometime other. So for that, this is hypercalcemia presenting as hypercalcemia, which turns out to be a MEN2A.
Thank you, Dr. Meenal. It was a very, very interesting and an excellent presentation. Ma'am, I wanted to know, is male hyperparathyroidism common?
Very. There is no gender bias with parathyroids.
Okay. So there are so many patients with rare and poorly understood causes of increased hypercalcemia. And I think improving and understanding of our calcium metabolism and additional areas in clinical investigation might help us to make the diagnosis more clearly and effectively.
So the learning is that whenever you come across a case of raised calcium, the first thing is ask for a PTH. If the PTH is raised, then it is a case of hyperpara. So do look for even the serum calcitonin levels, and also look for some PHO mass or adrenal mass if missing. Look for a family history in details. So that is the take-home messages.
Meena ma'am,
Yes, please.
how we would, like in an OPD basis, would diagnose hypercalcemia? I'm not talking about hyperpara, but in an OPD setup, how you would differentiate hypercalcemia? What are the other conditions where a patient could suffer from high levels of calcium?
Dr. Abhishek, that is very, very, very interesting question and very relevant question, because clinically, if a patient is coming to you with very common symptoms like polyuria, polydipsia, and you find there is fatigue and constipation, especially the muscle fatigue, the muscle cramps, muscle pain, along with constipation, you just think of maybe it is hypercalcemia. Because these are typical triad: a polyuria, constipation, and muscle fatigue.
That's
Otherwise, this is not very common for any patient presenting with this typical triad. So if you think there can be a raised calcium, so do always, whenever we ask for a renal functions, most of the time, most of the labs give us a calcium along with the renal functions associated. Otherwise, if you are ruling out all the other things like polyuria, what comes to your mind is diabetes. So if sugars are normal, if the sugars are normal, HbA1c is normal, if the patient is still having polyuria in no urinary tract infection, we do think of hypercalcemia.
I think
so fibromyalgia is one of the major causes of hypercalcemia. Could be fibromyalgia.
Fibromyalgia will mimic hypercalcemia clinically. Fibromyalgia will also present with muscle fatigue, but fibromyalgia does not have polyuria. Polyuria, bone pains, easily fractured bones, osteoporotic bones. This is not a feature of fibromyalgia. Constipation again is not a feature of fibromyalgia. Fibromyalgia will only mimic as muscle fatigue.
Okay, that's true. Thank you, ma'am. Thank you.
First of all, I would like to compliment Dr. Meenal Mohit ma'am for presenting this case and she has presented all the three possible scenarios. Till the time we had the history of the family history of the pheochromocytoma in the mother, it was looking more like a case of hypercalcemia only, and she suggested that what could be the line of management for this case. Then she also presented that when we take everything together and you work up, then the patient turned out to be of MEN 2A. And finally, even after treating and doing everything, what should be done to the family member? The mother also went for the thyroidectomy because there was a risk of medullary carcinoma of the thyroid in that patient. Also, the red oncogene was positive. And third thing was that she also highlighted what could be the complication. Even after the following up and doing everything, the patient landed up with the hypocalcemia and the tetany. So what started with the hypercalcemia, she followed till the patient had the tetany and everything. And I think it is a very beautiful case. Dr. Anumati Jain is also highlighted very beautiful pulse of the neurology to clinical cases. And now we have Dr. Anuj Maheshwari sir also with us, the governor of American College of Physicians India Chapter. And this program is incomplete without his presence. So welcome, sir. We really missed your presence during the cases, but I am sure you will have something to add to it, sir.
The show must go on. And this is the best example what the Amit is continuing, even if I am not there. So this is the best thing. And this is actually a spirit of our American College of Physicians India chapter. Teamwork is going in that way. Whether myself is there or not, whether governor is there or not, every council member is capable enough to do as much as good work as Dr. Anuj Maheshwari can do. And Dr. Amit Gupta is the live example of that. Dr. Purvi is also there. And Meenal has been one of the very good contributor of the American College of Physicians for last many, many years. And we are also looking forward to the new contributors which will be coming up in the future or in the coming days, like Dr. Jyoti Vajpayee, Dr. Preeti, Dr. Anubhai is already with us as a council member. So we are proud of our all council members, and I am proud of all council members. So and this is really a proud privilege for me to say this. So wonderful program is going on, and I wish it's to be continued like that. Although I did not listen the previous case, so I'm not going to comment on that. But the next thing, whatever will be going on, I shall be definitely be a part of that. So please carry on, continue the program as it was going on.
Just to inform you, sir, today we finished in time. We started in time. So both the speakers, they also finished in time. So we have
Very good,
finished with
very
both the cases now. And we were just continuing with the discussion. And Dr. Meenal, I would like to ask one question to you. Had there been no history of pheochromocytoma in the mother, and if it would have been a straightforward case of hypercalcemia, then what would have been your line of management in this case? Surgery or the medical management?
I'll surely come back to you. But sir, good evening, sir. It was nice to have you here.
Hello.
So Amit,
Good
yes,
evening.
very true. Most of the cases of hypercalcemia, we do workup only for the parathyroids. And if it is a case of parathyroid adenoma, the line of management becomes first a scan. A system may be scanned, which gives us the tumor mass where to look for. Then one of the surgeons from our team, maybe a ENT surgeon can do it, or the onco surgeons can do it. We go for a parathyroid adenoma resection. And if it is parathyroid hyperplasia, then we go for a total parathyroid, all the 4 glands, except that we save a part or portion of the parathyroid and we re-implant it subcutaneously, either behind the muscle, the neck muscle with the sternocleidomastoid itself, or we can even place it below the forearm. So that is a usual management. And then we follow up the patient for PTH. One important point to remember is when you're dealing with a solitary mass or a hyperpara is, always remember to send one PTH sample intraoperatively. Because when the patient is already on the OT table and the neck is already opened, while the surgeon is still exploring, you have to document that the surgeon has taken out the right mass, the right adenoma, and the PTH has to drop less than, come down by at least 50% intraoperatively. Otherwise, if the PTH is not falling below 50% within the on the operative table, then the surgeon has to explore the other glands also. That means he is on the wrong gland. So otherwise, that is a one take-home message, that the intraoperative PTH sample has to be sent. And then follow-up is with the simple calcium levels, vitamin D levels, and maybe you can also follow up with the PTH levels.
Dr. Anubhuti, I would like to ask one question from you also, since now we are living in a post-COVID era. And during COVID-19, you must have seen a lot of cases with the CNS presentation of the COVID-19 also. And you had done a case series on CNS tuberculosis, almost 100 cases. Could you find anything which can confound the diagnosis of post-COVID-19 CNS tuberculosis or post-COVID-19 long COVID symptoms in the CNS or CNS cases with the long COVID? I think ma'am has just left. No issues. We will take this question at some later point of time. So we have, so today's case file is conducted by Abhishek Srivastav and Dr. Jyoti, and they have wholeheartedly participated in this program. And Dr. Abhishek, you can ask questions if there are any. We can proceed, or else
yes,
we can.
Amit, this is better idea. We should give the more opportunity to our people, those who are conducting the program.
Yes, please, Abhishek.
Yeah, thank you, Maheshwar sir. Thank you. And I've asked the questions.
Welcome.
And the
Hello, there was some problem in the internet. I couldn't hear the question. Sorry.
Dr. Anubhuti, thank you for joining back. I was just asking that we have now we are in the post-COVID phase, and during COVID-19, you must have seen a lot of cases with CNS presentation of the COVID-19. And considering your case series of CNS tuberculosis, can you get something with the post-COVID or the long COVID? You can get something like you get a clinical presentation in CNS tuberculosis? Dr. Anubhuti?
I think connectivity.
I think she got
poor,
disconnected
so.
again. I think she got disconnected.
In fact, in our own clinics, we have seen a lot of the psychological and depression kind of the patient, but neurologically, patient might have. In fact, we used a lot of anticoagulant, but I did not see any patient in the stroke or any kind of the ischemic situation in my clinic. But I think the people, those who are working with the specialty, they can do better and they can better tell to us.
I think I missed a question, but it was about the neurological manifestations post-COVID, right?
Yes.
Yes,
Coagulation was the
So
issue always.
was
Coagulation disorders, and in fact, anticoagulants has been used in the post-COVID era in the COVID patients in lot of amount. So there are possibility there could have been chances of getting these kinds of the ischemic episodes. Those ischemic episodes may be in CNS, maybe in any other part of the body. So obviously, I think what the Amit is really looking for to answer you regarding that.
Thank you, sir. Thank you for answering that question.
There is there was something called cardiac attacks. Then we heard about brain attacks. Now we will be coming up with digi attacks. So these technology attacks are bad. Madam's laptop crashed today. Now, madam.
Technology attack, Amit is known for the technology attack.
So
In
digi
the
attack
coming
is
days.
a new entity. So we have digi attack as a new entity, you know, the digital attacks.
yes.
So I think our program is over. All the three parts has been over, Amit.
Yes. Yes, sir, we have discussed all the two parts, the cases as well as the case by the Dr. Meenal as well as Dr. Anumiti. And as you know, the ACP chapter, sir, is already exemplifying the diversity, equality, as well as the inclusiveness. So our focus is to encourage equal participation from all the members of the American College of Physicians and whosoever is willing to contribute by any means. They can always write to the governor of the American College of Physicians, and they will definitely be accommodated for any program. So this is the message I wanted to convey.
Very interestingly, I must share it here. One of the person at the headquarters said that you are less inclusive or non-inclusive regarding the women in your programs. So actually, in India, the scenario is quite different. Less women are opting for the medicine or they are active in the medical field. With 75% women, those who opt for the medical career, they go for the obs and gynae. So in medicine or in physician group, we are left with again a very disorganized ratio or disproportionate ratio, that is 75% men and 25% women. So that situation becomes quite tough to involve in every program. But we tried, we discussed with Amit and we planned this, that more and more women can be included in the ECP file, because this is one of the important program of the India chapter, and India chapter is being recognized with this program. So this program should be participated equally with both the genders. So this is our future plans also, and in future also we should be very much inclusive, and inclusive not only from the gender side, but I am also having some ideas that we should also try to bring the doctors, those who are in the remote areas, those who are taking care at the primary healthcare centers. Nobody asked them to come on the bigger platform. I'm also looking for the inclusion of those doctors, those who are working in the remote areas, kind of the northeast, far northeast, and far past of the Rajasthan, where people are posted in the desert areas, and these people should also be given the appropriate chance to tell their problems as well as find their solutions on the ACP platform. So, Amit, we shall be planning these kinds of the program also in future.
So, sir,
Yes.
actually, I've already planned. I've discussed with two or three remote doctors, and they'll be presenting their cases in the next case files. So I've already discussed with them, and they have actually very interesting cases to discuss. They have actually shared with me, and in the next few case files, we'll be bringing those doctors who are actually very shy to come forefront and speak about their experiences and everything. So we'll be bringing them, certainly, that's for sure.
So we can also give a mail, or we can also ask to all our members, especially those who are living in remote areas, So whatever they are coming across with any unusual case or any weird kind of the case, a weird kind of the presentation, they should share it with us, and if we shall find it eligible to be kept in this ECP case file, and on the basis of that we can keep them rewarded and felicitated during annual conference also. So
Done.
this may
That's great
encourage
idea.
them to participate more and more here.
Anu sir, so we are almost in time. It is 8:30 and we have
Yes.
both the cases. So I will request Dr. Abhishek to give thanks to Dr. Preeti, Dr. Anumiti, Dr. Meenal, and our governor, Dr. Anuj Maheshwari, and then we can close this program.
Purvi wants to say something. Let her
Yes,
say.
Sir, I
Just a comment. So, Dr. Abhishek, since you are in touch with doctors from the remote areas also, in case they need any, technical support in the sense they want to organize the slides better or make the presentation, we can always, one of us can step up and help them so that, that shyness that they have of coming onto the Zoom screen and sharing, I think we can help them get over that.
Certainly,
Yes.
certainly. We have 30 or 40 bunch of doctors actually who are in the remote areas, and they are very actually like hardworking, and they have actually very interesting cases and knowledge to share with us. We actually should actually bring them up and should show them the cases.
So Abhishek,
That's
you
all.
take this responsibility and you collect all those cases and then send to Amit and me, and we can find the best one of them and we can invite those doctors here
Sure,
in the ECP
100%,
case
sir, 100%.
file.
I'll share the cases, whatever the
Yes.
cases they have.
Yes.
So, thank you, Anuj Maheshwari sir, Dr. Amit Gupta, Anubha ma'am, Dr. Purvi ma'am, Dr. Jyoti, Dr. Meenal ma'am, Dr. Anumiti for actually coming and sharing their views, their cases. And it was probably the most interesting, like the evening or the case files I've attended. So thanks a lot, everyone. And we probably would hope that next time, the few more interesting cases, which actually are very relevant to our practices, would come. The doctors from the remote areas would come up in upfront, and they would share their ideas and views. And with this, I would like to close the session. Thanks everyone for coming and sharing their experiences. Thank
Abhishek,
you.
just before we
Thank
sign
you.
off, we can switch on our camera and take a photograph.
Yeah.
I will request
Please.
everyone to please switch on their cameras, and then I will click a photograph.
Anubha's car will also be coming in that photograph.
Dr. Daria, you can also switch on your camera.
नहीं जला मैंने जला लिया
Right. So thank you everyone, and we will see you in another episode of ACP India Case Files next month.
Thank you.
so much,
Thank
sir.
you.
Thank you.
Bye.
Meenal ma'am, thank you.
Bye.
Good evening, Anuj sir. Thank you so much, sir.
Bye-bye.
Meeting.